Good afternoon, everyone. This session is being recorded. I'm Veronica Shalette, Program Director in the National Cancer Institute's Healthcare Delivery Research Program. Welcome and thank you so much for joining the third session of our four-part series on telehealth and cancer care delivery during the time of COVID-19. The goal of this series is to understand current practices and explore scientific gaps related to telehealth and cancer care. And we hope that our attention to this issue stimulates innovative research on how telehealth-focused care can improve clinical practice quality and healthcare outcomes. The topic for today's session is enhancing cancer care of rural dwellers through telehealth and engagement. And we're very happy to have an NCI established investigator, Dr. Debra Friedman, lead the discussion on this topic for us today. All lines are muted, but we welcome your participation. At any time during the session, feel free to type questions in the chat box, and then they will be read after Dr. Friedman's presentation during the Q&A session. Also during the Q&A session, you have the option to continue to use the chat feature or use the raise hand icon, and we will unmute your line for you. If you have any questions or comments about the cyber discussion, please send us an email at hctcyberdiscussions@nih.gov. Closed captioning is available by selecting the media viewer panel on the right side of your screen. And want to let you also know that we have integrated a few poll questions during today's session in Mentimeter at menti.com. So you can use your computer or your handheld devices to go to menti.com. And to respond to the poll questions, you'll be entering the code 27170929. So our first question is a poll question that asks the disciplines that are represented on the call. So if you please will let us know if you are a clinician, researcher, patient advocate, health administrator, or more than one of those options. You can select more than one. And if you don't fit any of those categories, you can select other as well. So if you just take a few seconds, please go to Mentimeter at menti.com and use the code 27170929. Okay, it looks like as usual, we have more researchers, but we're happy to have the health administrators, patient advocates, clinicians, and those that fit more than one category. So next, I'd like to introduce our speaker, Dr. Debra Friedman, is a professor in pediatrics in the Division of Hematology and Oncology at the Monroe Carroll Jr. Children's Hospital at Vanderbilt. She's an E. Bronson Ingram Chair of Pediatric Oncology and the leader of the Cancer Control and Prevention Program, and directs the cancer survivorship programs at the Vanderbilt Ingram Cancer Center. Dr. Freeman has leadership roles in the Children's Oncology Group and is an internationally recognized expert in cancer survivorship, participating in projects evaluating best practices and various models of care delivery. Dr. Freeman shared 2 background articles to prepare you for today's session that you can also find in the chat. So now, Dr. Freeman, I'm going to turn the session over to you, and thank you so much for leading today's cyber discussion. You're muted.
Can you hear me now?
Yes, great.
Great. I'm just trying to advance this. The slides won't advance.
I'm going to recast the controls to you, and then just let me know if you're able to advance them.
Okay. Cannot advance.
You'll just have you clicked on the presentation and then just use the arrows on your keyboard. And if not, you can just say next. Oh,
There we
there
go.
you go. It's not very, there we go. Okay, I'll try. If not, I'll just say next, okay? Okay, perfect.
Great. Great. So just to give some background in terms of rural health, as people well know, about 20% of Americans live in rural areas. These are areas that have elevated cancer incidence and or mortality compared to urban communities. Some of these counties also have among the highest rates of poverty in the United States. So when we think about cancer care really across the continuum, there are significant challenges with respect to treatment, supportive care services, transportation, and finances. In addition, providers who work in these areas and provide cancer care to the community have limited access to comprehensive care services. So this creates the setup for what we know is kind of an urban, rural, high socioeconomic status, low socioeconomic status split in the country, which results in some disparities. Next slide, please. So the Vanderbilt Ingram Cancer Center is situated in an area of the country in the Mid-South that has very high incidence of both cancer as well as high mortality rates. Our catchment area includes all of the state of Tennessee, as well as part of Kentucky and part of Alabama. And as you can see on the map shown here, the light green areas are really not rural areas, but the dark green areas are. So of the 123 counties in our catchment area, 57% are rural. And that makes up 25% of our catchment population, which is a little bit higher than that of the United States. Next slide, please. So in order for me to get an idea of the audience, I'd like people to put into the poll what population they serve in terms of their research, their clinical care, their advocacy. Great. And I can see that as this is kind of moving ahead, that many of you serve both rural and urban populations. And what I'm going to talk about today is really designed on using telehealth in research settings, but designed in a way that everything we're doing in the research setting hopefully can be translated later in a dissemination and implementation mode to actually provide service. And things that we're talking about, while geared towards rural communities, there are certainly urban communities that can benefit from the same type of methodology. Next slide, please. So I'd be interested to hear how people are using telehealth now in terms of research studies, clinical care, to assist with cancer screening, survivorship, or, for example, providing hereditary cancer evaluations for patients. Well, this is nice to see that that people are using telehealth really across the spectrum, and I'm sure people are using telehealth in many other areas as well. Next slide, please. I apologize, I'm not able to move the slides. So the other thing I wanted people to think about before I kind of go into the meat of the talk is, can you kind of put up up to 3 words for challenges that you see providing care to rural populations, because I think this will be important for us to keep in mind as we move ahead and start to think about what the barriers are for our rural populations, as well as what solutions we may be able to engage. So I see kind of the 3 words that come up are, I see things about resources, travel, literacy, transportation, specialist handoff, access, provider shortages, poverty, transportation and travel are kind of right here in the center. And one may argue that that affects everything around kind of this word map. So in keeping all of this in mind, can I have the next slide, please? I'm going to take you through a series of research endeavors that we've taken here at the Vanderbilt Ingram Cancer Center to really think about how we could bring cancer prevention and control efforts, as well as cancer treatment, to our rural communities, because our catchment area includes 57% rural counties. We cannot and do not expect the people who live in those communities to travel extremely long distances to come to the NCI Comprehensive Cancer Center. So instead, our goal is starting out with research so we understand what works and doesn't work, and then translating that research to clinical care and translating that research to the community. So really going from kind of the lab to the clinic to the curbside, so to say. We really want to see how we can bring what we have at the Comprehensive Cancer Center out into our catchment area. So bringing us to the catchment area, not the catchment area into our doors. So this started with a supplement to our Cancer Center grant to look at opportunities to build capacity for cancer prevention and control efforts. Next slide. And what we did was we conducted a multi-level cancer care needs assessment in 70 counties of the VIC catchment area. And we've also established a network of rural health providers. And we really want to focus on using this network, and we have been, to get ideas about what's the next thing we can be doing. What are the gaps? Are we filling those gaps? What are some new areas that we can help these rural healthcare providers with? Next slide. So the first thing we did is we kind of added to community health needs assessments that were already going on in rural hospitals in our catchment area, as well as urban hospitals in our catchment area. And as you can see by the figure here, the tan bars are the rural hospitals, the maroon bars are the urban hospitals, and the blue bars are the totals. And we asked about priorities: cancer, obesity, physical activity, access to care, smoking, social determinants of health. And then we asked about screening. We asked about breast cancer, lung cancer, and colorectal cancer. And then we asked about implementation strategies to address those things, focusing on physical activity, obesity, cancer screening. And then we looked at breast cancer screening, lung cancer screening, and colorectal screening. And as you can see, there were some differences between priorities set in these needs assessments between rural and urban populations. Next slide, please. And then we did a telehealth survey. And what we did was we went out into these counties and we picked some urban counties shown in maroon and some rural counties shown in blue. And we said, if we could provide services in these areas, would you have interest? And what we're showing here is those that expressed high or very high interest in these services. And we asked about kind of pre-screening for lung cancer screening. And the reason we're saying pre-screening is because to do lung cancer screening, you need a CT machine, and there's no way to do that, obviously, via telehealth. We talked about hereditary cancer assessment. We asked about survivorship follow-up care. We asked about providing information on HPV vaccine, doing telehealth smoking cessation clinic, and for providers, providing access to a tumor board here at the Vanderbilt Ingram Cancer Center, whereby they could provide, they could have access and present cases to us. And as you can see, all of these priorities that were ranked as high or very high interest were actually a little bit higher in rural communities for the most part than in urban communities. And particularly when we look at that molecular tumor board, although the percentage itself was lower, there was much more of a difference between the urban and the rural communities, which is not surprising to us because providers who are out in these communities really wanted, and when we asked for comments about this, they really wanted access to the comprehensive nature of our cancer center, and this is one way of providing it. And we're actually now doing this in a study that I'll tell you about in a little bit. Next slide, please. We also held meetings with our community advisory boards, our rural health providers network, focus groups, and did key informed interviews. And really what we came up with was the top needs that came across was access to educational information, barriers to care, better support for patients and caregivers. And when we asked them, how do you think we can help you? The things that came up was for access and barriers to access, really providing as much as we can via telehealth, but also having local on-site patient navigators. And the other recommended strategy was improved coordination between oncology and primary care providers. And we completely concur with that. And we're doing that within our rural provider network now. Next slide, please. So the next thing we did, again, through another supplement for our to our cancer center support grant, was looking at cancer survivors who have completed cancer therapy to better understand if they were receiving post-treatment surveillance as well as survivorship care in terms of did they have access to a survivorship care plan? Did they understand what therapy they received? And did they understand what kind of specialized monitoring they may need for their healthcare needs outside of cancer because of the exposures they received during their cancer therapy? Next slide, please. And this is an ongoing, this started as a supplement, and now we've just continued it past the supplement period to get more information. So after we kind of first understood what the issues were and learned very quickly that rural cancer survivors really did not have access to risk-adapted guideline care focused on the needs of those survivors, we have been testing an implementation of a survivorship care planning using patient navigation and telehealth. And the way this works is providers at some of our rural sites are referring their patients who have completed therapy for a survivorship care plan. Our nurse practitioner here who works in our survivorship clinic gets the medical records, creates the survivorship care plan, and then does a telehealth visit with the patient together with either a nurse or a lay navigator in their clinic. So that navigator or nurse is there to hear what the recommendations are and then to help find local resources for the patients to be able to carry out the recommendations of the survivorship care plan. And what we've been collecting now, as we've been doing this, is what works, what doesn't work, and we've been able to tweak our process along the way to ultimately have this as a large-scale implementation, and this can be just something that is provided. And we are not charging for this. We're not providing this as a clinical service. We're providing this in the setting of research at this point in time, so we can really learn and then implement it in fully in the clinical setting. Next slide, please. So this kind of set the stage for what is now being funded through an R01 through the NCI, which is really looking at cancer care of rural dwellers through telehealth and engagement, or the ENCORE study. Next slide, please. And this is a multi-level telehealth-based intervention. At the provider level, providers are able to present their patient at our molecular tumor board. So this has several purposes. One, they can present a patient for whom they have either genomic or germline or both genetic testing and get information about what it means. Do they have variants of uncertain significance? Do they have findings in the tumor of genes, but these aren't driver genes of that tumor, and should they be targeting it just because they found an abnormality in that gene in the tumor? They can also present cases for whom they have no genomic testing to say, would genomic testing be helpful, and how can we help them get that genomic testing be done? And similarly, is this a patient who might benefit from hereditary cancer screening? And we'll talk a little bit later about how we're bringing that in combination with our molecular tumor board. And at the patient level, we are providing, it's a randomization for supportive care intervention, which is a 6-week interactive program called Cancer Thriving and Surviving, versus having online education. And I'll show you in a little bit what that education looks like. And we are doing this across a number of sites. And then again, as we're actually conducting the research, we're finding things that work well, we're finding things that don't work well, and we're actually, in an iterative fashion, as we're conducting the research, making small changes to better design the study. And this is an ongoing study. Next slide. And these are the sites that it's being conducted in at this point. So we have some sites in Mississippi, in Western Tennessee, in Eastern Tennessee, and actually an affiliate of one of our Eastern Tennessee centers, the Ballard Health Center in Bristol, Virginia. Next slide. So for the first aim, at the provider level, we're really looking at how are they using our tumor board, and are they able to adhere to the recommendations? So for example, if they present a case and there's a genomic finding, and that genomic finding is going to be associated with a targeted agent that should be used for that patient, does the provider, incorporate that into their treatment plan? And if they don't, why not? Is it because that person doesn't have adequate insurance to cover the cost of that targeted agent? Is it because they don't feel comfortable because they don't have experience with the targeted agent? Is it because the patient did not want that because they feel like it's not proven yet? Those are the kinds of things we're collecting. And at the patient level, we are asking them, did the provider share with you what they learned in the tumor board? And what did you understand with it? And how are they adhering to their treatment plan as they go along? And what kind of challenges are they having? And we're getting also information on psychosocial and functional well-being, on how they feel like they can communicate with their provider, and of course, gaining information on progression-free survival to see if ultimately we're making a positive impact in delivering cancer care to these rural communities. Next slide, please. And these are examples of some of the implementation questions we're looking at along the way. So we can scale this up and ultimately have this as a standard of care, providing these services to both patients and providers via telehealth. Next slide. And these are the patient intervention arms. So the top part of the figure is Cancer Thrive and Survive. And this is an evidence-based program. It was designed to be done in person. We actually, when we wrote the grant pre-pandemic, and we wrote it deliberately to be delivered completely in telehealth, not to be in person, because we knew we were dealing with rural communities that were spread across our state. And then even within the rural communities, we knew that patients had to travel large distances, and we didn't want them to have to travel for a support group. So we designed this from the get-go to be telehealth, which was very fortuitous, because then as we got, very soon after we got funding, pandemic hit, and there was no way we would have ever been able to do it in person. So we've set this up via telehealth. And as I said, it's a 6-week program, and the content is on the top. And then what we did is we went and we found evidence-based education through NCI, NCCN, CDC, et cetera. And we tried to match the subjects that the patients would be talking about in the Cancer Thrive and Survive. And we've created a website, and the patients who are randomized to the education arm have go onto that website and can navigate through all of those educational modules over that same 6-week period that the intervention group is meeting via Zoom for the self-management group. And then both groups are completing surveys. And what we want to see is, does the self-management group make a difference? Is that the best way to provide support for these patients? Or can you provide the same information on a website, which obviously is more cost effective? But really, is there an advantage of that interaction? Our hypothesis says there is, but that's what we want to prove. Next slide, please. So through a supplement to this R01, we are designing an algorithm, a survivorship algorithm, next slide, called Filter. And the goal is to create an algorithm using informatics whereby we can determine, based on a number of factors, disease, treatment, demographic, and non-oncologic health factors such as hypertension, cardiovascular disease, history of stroke, that will allow people to risk stratify what post-treatment survivorship care should look like. Right now, the guidelines that are out for cancer survivors are a little bit of one size fits all. They're largely based on limited expert opinion, largely based on exposure. And they really don't look at who has a very low need for survivorship care that could be provided in the course of their primary care. Who really needs to have survivorship care that's maybe directed by a survivorship program at a cancer center or a cancer practice, and who needs something in between. So we are creating a system where we're going to try to get this, and then developing a REDCap tool that will translate the algorithm into a clinical practice calculator, so providers can actually put information in and then get back, your patient requires a medium level of survivorship care, and here are some models that might fit that. Next slide. So this is our approach to develop the risk stratified survivorship model. we are having oncologists from all specialties ranked to judge the relative contribution to survivorship care. And with iterations, we're going to create a survivorship follow-up complexity score and then build that into the REDCap. Next slide. So these are the products. So this is Filter. So this is the first of its kind that we're aware of. It's a crowdsourcing platform to assign risk scores to survivorship using synthetic cases generated from treatment, sociodemographic, and comorbidity risk factors. So as you can see, you have case 1, case 2, and what happens is the person logs into the Filter system. These cases come up. It takes less than pretty much like a second a case, and they just mark which of these cases would have a higher survivorship need. And then behind the scenes, the platform is calculating scores. And then at the end, next slide, this is all going to be translated and create the backdrop for a REDCap risk calculator. So then what would happen is the provider would go into the REDCap and by a series of clicks, so this is just part of the screen I'm showing you, say, oh, this patient has had resections in these surgical fields, or they've had removals in these surgical fields. And then there's a field for radiation therapy. There's a field for chemotherapy. There's a field for comorbidities. There's a field for socioeconomic status. There's a field for distance from the cancer center. So all of this in the field, it's all kind of quick clicks. And then what will happen is, because the algorithm created this risk score, it's in the background of this calculator, something will come up and say your patient is at X risk. And as I said, then connect them to established models of care. Next slide. Together with, so that is, and we have another supplement because we really thought an important part of care is to think about how can patients be tested for cancer predisposition counseling and testing. We know that access to genetic counselors and to medical geneticists is limited. It's limited across the country, regardless if rural or urban. There's actually a nationwide shortage now of both geneticists and genetic counselors. In addition, we know that from our telehealth surveys and our surveys that we did when we first started this through our first supplement from NCI, we found that this was a really important issue to the patients and to the providers in these rural communities, but they really had no access to be able to get this care. And they didn't want to travel all the way, across the state to come to our genetics clinic. And truth be told, we wouldn't have the bandwidth to have all these people come to a clinic. So this was set up to do this versus on telehealth. Next slide, please. So the aims of this study are to develop and pilot test point of care genetic testing and germline genetic testing among rural health patients, and then to assess the barriers and facilitators. Next slide. So this is the way it works. So what happens is a patient is identified who the provider thinks may need an assessment for cancer screening. So the current paradigm is the arrow at the top. And so what happens is they refer the patient for genetic counseling. The patient undergoes pre-test genetic counseling and signs consent for treatment, for testing. They get a sample collected, they get a genetic test report, and then they have to go back and get post-testing done. So this requires the provider to send that patient to a cancer genetics clinic. What we're doing through this is the bottom part. So the patient completes an online study consent and medical record release forms and an initial survey with family history. And the best part of this is if anybody's ever walked into an office and somebody asks you for an extended family history, a lot of people don't have that at their fingertips. So if they're doing this online, they can be like calling their relatives and saying, oh, I remember, what did grandma have? Did she have breast cancer at an early age, or was it really, something else? And they can get actually a more accurate family history. And then the patient undergoes an automated pre-test genetic counseling to inform them about the testing consent. A genetic counselor reviews and gives a recommendation based on what the patient put in and what the provider put in. So then a genetic counselor is reviewing this, goes back to the provider and says they meet criteria to have germline genetic testing done, or they do not meet criteria. At that point, that information goes back to the provider. The provider talks to the patient and says, your information was reviewed by a genetic counselor and they don't think you meet criteria for genetic testing. There's no reason to go forward. Or they think you do, and they go ahead, they get the testing. The testing comes back through the same portal to our genetic counselor, who is then able to interpret the results. And if there was nothing found, they're able to just let the provider know there was no abnormalities found, and that provider can tell that to the patient. Or they can do genetic counseling via telehealth with the patient and explain what was found. Next slide. So the value added is very clear. We're able to provide cancer education to the patient. We're able to generate a family history. We're able to determine whether the patient meets clinical criteria and guide what tests may be indicated. So if we tell the provider that we think that they should have genetic counseling, we also make recommendations on what panel they should send. And then after the testing, we can really interpret the results in context of the history, identify discrepant or complicated results, and then offer additional thoughts. And this is all done via telehealth. Next slide. So really, in conclusion, we know that there are differences between rural communities and urban communities in terms of cancer screening, early detection, incidence, and mortality. We know from our work and others that rural communities are eager for increased services, but they're not able to come to the big cancer centers. We know that we need to partner with them, and that partnership must be bidirectional, and it takes time. And we've been very fortunate, thanks to NCI, for several years of continuous funding through supplements and our R01, and then supplements to our R01, to be able to do this in an iterative fashion and to be able to build partnerships with multiple rural clinics now, to be able to test how we can better deliver cancer care, cancer prevention. And while we're doing this right now, largely in a research setting, I would argue that what we're learning can bring clinical care to these rural communities as well. And that is our goal, is to test what works in the research setting, and that using telehealth bring it to our rural communities. Next slide. And I'd just like to end by acknowledging all the investigators on our team, our research and our community outreach team, and of course, the National Cancer Institute for their very generous funding. Thank you. Next slide. And be happy to take any questions now.
There are a few questions, Dr. Friedman. I have one question. For your 6-week telehealth Strive and Survive intervention program, did you provide computer, tablet, or smartphone to participants to participate in this?
Yes, good question, Veronica. So that was one of the things we learned very early on. As we designed this, we actually had our sites do, as they approach patients, find out, do they have a device? So do they have, because this can be done on a smartphone, a tablet, desktop, or laptop computer. So we first found out if they had a device. And then we also found out if they had adequate broadband, because we really want people to be doing this from their homes. We did not want people to have to go into the clinic and sit in some conference room and do it. So we are providing either limited broadband for like a 3-month period while they're in the study, or we're loading a device for the patients who need it so they can participate. And one of the things we're collecting as part of the study is what proportion of patients actually needed that assistance. Because if we're going to build this and scale it up, we need to know if that's part of the needs. And we can bring that information back, obviously, to the public health sector and say, hey, we've got to increase broadband. Look, we have this great intervention, but in the end, you know, these people need access.
Another question that I had is, what impact did patient navigation have to help with community resources, and how has COVID impacted community resources for your patients?
Yeah, so we're still collecting data. The navigators, we're using a combination of, we're using navigation via telehealth, because some of these clinics had patient navigators, but some of them did not. So we're actually using navigators from our cancer center who are working with their navigators to try to expand that and doing that via telehealth. Some centers have lost research staff and navigation during COVID, which has impacted the study. So we're not quite as far along as we would like to be. And that's why I don't have results yet to share, because those are some of the positions that were adversely affected by COVID. The other thing that's been affected by COVID that I think everybody knows is screening. Cancer screening went down precipitously during the pandemic. Patients were afraid to go, places weren't going, patients were canceling. We're starting to see that change, but during the pandemic, we could give recommendations, but patients were unable largely to carry out the recommendations. So we want to make sure that we're circling back to them as we're starting, hopefully, all to see light at the end of this tunnel. And so services are starting to open up.
So we did have some questions that did come into the chat. The first question is, have you found that a large portion of your patients have unreliable internet access, thereby making these types of communications difficult? If so, how do you overcome that barrier?
Right. So we're collecting that information. So I don't know yet if the majority do have issues with unreliable service. That is something we're going to collect. And then we want to bring that information back to the rural centers, to health councils that we work with in the area, to local governments in the area, and say, hey, we can bring our services from the NCI Comprehensive Cancer Center in the state to your community, but they don't have broadband. We need telehealth isn't going to work if you don't have broadband. And again, what we really want to do, bring as much as possible to bring as much telehealth from here direct to patient, and not have to have the patient go to a location to then participate in the telehealth, because we think that that's going to serve as another barrier.
Question in the chat, is this program on red caps only, or does it, and then genetic testing, in parentheses, linked to medical record?
I'm sorry, I lost part of that question.
Is the program on red caps only, or does it, particular genetic testing, link to the medical record?
If the genetic testing that's actually done, so all of the information that we provide is between us and the provider, and it's up to the provider to include that in the medical record or not. and they order the genetic testing themselves. The genetic testing is not ordered by us or by the study. We make a recommendation to the provider that testing is indicated. And then when they do that testing, it is up to their discussion between them and the patient, whether that testing goes into the medical record. From our perspective, it's just kept in a protected red cap.
Another comment is, my concern is the lack of providers in healthcare institutions that don't have or utilize genetic counselors to improve our rural health outcomes.
So we do know that we're looking at this way of providing genetic information via telehealth, so we could utilize genetic services in institutions that have genetic services for those who do not. And we know that's not a perfect solution, because at some point you can imagine that we could, saturate the ability of, genetic counselors, geneticists, even in large institutions. But part of this project is to assess what the need is and what the uptake is, and to try to see if we can then do additional training of providers in the area of genetics with kind of cancer centers that have genetics, hospitals that have genetics, potentially cross-train people in genetics in other areas, and really work together.
Another question, the lack of survivorship plans has been an issue as patients transfer care from the oncologist to the primary care provider in the rural area. Have you addressed anything with the rural primary care providers, resources, etc., or is this all focused on having the oncologist / cancer center going to the rural areas?
So that's a great question. And we are working not only with these survivorship care plans that we're helping. Part of the goal of this program is to provide this by telehealth, but also to provide training for primary care through our network on how to actually develop a survivorship care plan. We have another project going on, aside from the ones that I talked about, where we're actually working with an informatics, a small business informatics firm funded through an NCI SBIR, and we're trying to create a mobile app that could be used for oncologists, primary care providers, patients, depending on which screen they're on, to actually automate and create survivorship care plans. We completely agree that this can't only be on the oncologist and the cancer center, and this has to include training of primary care providers to provide these services as well.
Thank you. Another question. Thank you guys for so many questions. This is great. How are you measuring adherence to treatment plan and also patient-provider communication?
So the patient-provider communication, we have a survey, and we're happy to, and I'm happy to send that information afterwards on any of the tools that we're using, and it can be shared. I'd be delighted to do that. We can get that uploaded. And we also have a survey for the patient adherence as well. And again, happy to share those.
Another question, is data publicly available at this point?
The data is not publicly available at this point. The data, let me rephrase that. The actual data from the study, the results from the study are not publicly available because we're still in a study, but we are happy to provide any information on our methodology or the surveys we're using, and we're happy to provide that.
Thank you so much. Is their family history program completed?
I'm sorry?
Is the family history program completed?
It is not.
The next question, could you comment on the cultural characteristics of the rural communities in which you've conducted these studies and the impact of this cultural context on the study design and interim findings?
Sure. So what we did is as we designed this, we had our community health educators, as well as our navigators and our investigative team and patient advocates meet with health councils as well as staff in the rural clinics to be sure that what we were providing was culturally appropriate for the population. So everything we've done along the way has been in the vein of community engaged research. So we have not just said, okay, this is the way we're going to do it, but rather these are the surveys that we're going to use. This is what we're asking patients to fill out. Can you give us input on it? And this has been an iterative process to be sure that it is appropriate. And as part of our evaluation, we're going to be collecting information on, usability and satisfaction with the whole process, as well as the individual instruments.
More questions, which is good. Do you have any early evidence about rural residents' preference for telehealth? What were some of the strategies used to overcome hesitancy?
So actually, it's very interesting. The patients we've really the only hesitancy was, they didn't have broadband or they didn't have a tablet. But they really wanted to participate so we really haven't had a lot of hesitancy. It's kind of interesting. It was more hesitancy on the provider's part, that they were afraid this would be too burdensome on their patients. But actually what we presented, when the studies have been presented to the patients are very excited to do this. We also kind of have built in what I call tech support. So we have a study toll-free number or study email. So if anybody's having trouble with anything in terms of the technology using the telehealth, we have kind of on-site assistance. But most people have been able to manage it without an issue.
Great. Since each rural areas have unique characteristics, what factors are needed to be aware of as we think to expand this effort nationally?
Yeah, I think that's a great point. In part, that's why we've chosen rural areas in kind of different, so our rural areas are not all the same. So the rural areas that are closer to Memphis are rural areas that are serviced a little bit, kind of on the border of urban areas, where the areas in East Tennessee are areas that there are fewer practices. And then the areas in Mississippi, although they're part of the whole Baptist Corporation, they're a little bit more isolated. So we've deliberately chosen practices that are a little bit different to try to understand, practices that are different. And we're getting information on, what worked, what didn't work, what was hard at the patient level, what was hard at the community level, what was hard at the practice level. Hopefully that information can then be used by other communities. And we're also collecting data on the characteristics of all the practices. So even though they may be different in other states, there may be one that's more similar or more different.
Then the last question is, did you collect costs associated with this project?
Did we collect costs? Yes, we are collecting costs.
That was the last question. Thank you guys so much for all the questions. I appreciate that. Thank you, Dr. Freeman, for what you're doing and for sharing your research. This was an excellent session, I think. So I just want to share and bring your attention to the participants. The NCI has an active funding opportunity announcement that supports research to identify and improve telehealth for cancer care delivery. It is the Centers on Telehealth Research for Cancer-Related Care. The submission dates are in the FOA, and it is RFA CA 21-029. And if you have any specific questions, please contact Dr. Roxanne Jensen. Our next session is on October the 12th. Dr. Anna Maria Lopez from the Sidney Kimmel Cancer Center at Jefferson will be our featured presenter, and her talk will be on optimizing telehealth across the cancer care continuum during the COVID-19 national emergency. And the registration link is going to be put in the chat for you guys to register. And you can also find the registration link right here on the slide, as a matter of fact, and just pick up to your browser and also register. Let's see. So that's it for this particular session. Again, we're going to end a little bit early to give you time to complete the online survey so that we can understand how to improve our cyber discussion. So I just want to give one last thank you to Dr. Friedman and to our participants. Thank you so much for your time, participation, and interactive discussion. Thank you all so much, and we hope to see you back again in October.
Thank you, Veronica. Thank you to the NCI for the opportunity. We appreciate it greatly.
Hope to see you also in October.